So, good morning, everyone. I'm Andrew Jack from the Financial Times. So it's a great pleasure to help moderate this morning this session with Soumya Swaminathan from the WHO, the quite recently appointed Chief Science Officer for the first time. I guess we've got about an hour, and hopefully people have got lots of questions. So we'll have a little initial discussion, but then open it up to you within about 15 or 20 minutes or so. And I should say also at the start, I believe tomorrow there is a trip to the WHO, isn't there, which I think still has some places if people are interested. But unfortunately, Dr. Swaminathan doesn't have a lot of time after the session, so we definitely encourage you to kind of throw your questions out during the public session as well. So welcome, thanks very much for coming. Perhaps you might just start. I mean, some people would think the WHO itself, the World Health Organization, is fundamentally a science-focused organization. So why do we need a chief scientist?
Thank you, Andrew. Good morning, everyone. And it's a real honor and pleasure to be here. And it's lovely to be with science journalists, because I was listening to the speaker this morning, the plenary, and I think she brought up the issue of the lack of communication between scientists and journalists. And I hope that the new science division in WHO will take that advice seriously. And maybe that's one of the reasons or benefits of having a science division. So I think your question is a good question. The WHO, as you know, was founded in 1948. And from the very beginning, it was based on science and evidence. In fact, it's a normative agency. It's one of the few UN agencies that has a normative role in the sense of making standards and guidelines. And therefore, everything we do has always been based on science, and so it's been more implicit. And I guess now what's happened is with the transformation process, after Dr. Tedros became the Director General and he brought all of us in as his new team, there was a lot of introspection, a lot of reviewing of the work that we do in an attempt to make us fit for the 21st century. 70 years, it was WHO's 70th birthday last year, and we decided it was time to really, this is the time for change. And so the reason why we have a science division, and I'm really honored to be leading this as the first chief scientist of WHO, is twofold. One is to stay ahead of the curve, to be proactive rather than reactive, to anticipate things that could happen, especially in areas where there might be big impacts on public health, emerging technologies, frontier science, and every new technology, always has risk and benefits. So there are always potentially huge benefits, but also there are risks which need to be managed. So one of the units we're setting up is a foresight function, a horizon scanning function, really to look ahead to see what are those big technologies. Artificial intelligence is obviously one of them, but there are also now, with the gene editing technologies, very easy ways of editing the genome, and this has huge implications for treatment of diseases, but also in the agriculture, biotech sectors, in the pharma sector, and so on. And so many other areas which pose not only technological challenges in order to understand the science, but ethical and social implications which need to be discussed and publicly debated. And I think this is an area where journalists would play a very important role to start public debates on some of these issues. And we can talk about some of them in more detail. So that was one thought that went into creating the science division, is to really have a group of people who are focused on this, looking ahead of the curve and helping the world be prepared, the world of public health anyway. And the second major function of the division is to make sure that everything we produce, all our norms and standards and guidelines, are of the highest technical standards and highly, not only technically very good and excellent, but also relevant to the needs of countries, responsive, in the format in which end users really want to see them, and to ensure that everything we produce has a direct impact on people's health. And so there's going to be a whole new department that just looks and works across the house with all technical departments to see that that all our products meet these criteria, and that we apply the same uniform standards across the house, which we found does not happen. And therefore, that would be another major function. Just to give a very quick example, when we do our guidelines, we have to match, keep a balance between being very transparent, inclusive, listening to the voices of everybody, right from industry to civil society, activist groups, advocates, patients themselves, and so on. And on the other hand, making sure that the people who are actually in that committee writing the guidelines do not have a conflict of interest of any kind, because that would then completely undermine all our guidelines. And we've had a couple of instances where there have been some doubts in the past raised about the impartiality of people on those committees. And so it's important to have the right procedures and checks and balances in place where you listen to everyone, take everyone's views, but ultimately the decisions that are being made are based on very strong scientific criteria.
I can't risk asking then, give an example or two of that, where perhaps the quality standards weren't quite at the forefront of the best scientific understanding and consensus, let's say, or where conflicts in practice perhaps did raise concerns about the guidelines that were put in place?
Well, I think at the time of the H1N1 outbreak, and this was 2009, when it was declared as a public health emergency of international concern, there were, I think, unfounded allegations that WHO was influenced by the industry that was producing the drugs to treat influenza or vaccines to prevent influenza. And this was not the case, but I think a perceived conflict of interest should also be taken seriously, and we should look at why that happened. More recently, we've discontinued our opioid policy and our opioid treatment guidelines in children because they were developed in 2010 and 11, and we found that the scientific evidence now behind opioid use and the experience in countries like the United States clearly shows that there needs to be more rigor and control in the way that opioids are prescribed and used, and that patients are followed up. And therefore, we are revising the guidelines. We've come out with pain guidelines, treatment of pain in adolescents and adults, and pain not just with the treatment with chemotherapy, but also radiotherapy. That's specifically related to cancer pain. But the two guidelines we are revising now are the treatment of chronic pain in children, which is really something that there's very little evidence on. There are no randomized trials, and so it's a difficult area when you do not have trials to base your guidelines on. And the other one is a policy guidance to countries on how to regulate these classes of drugs, the opioids, so that on the one hand, you need these drugs for treatment of millions of people who are suffering from severe pain. And the fact is that on the one hand, you have the opioid overdose epidemic in a couple of countries, but on the other hand, you have actually tens of millions of people suffering from pain without access to morphine. And so WHO's guidance has to be balanced to ensure access on the one hand, but also to prevent this type of abuse that happened in the US, which is actually leading to a huge number of deaths every year.
So we might see a tightening for pediatric use, but on the other hand, where perhaps the sort of narcotics control policy world has driven for excessive restriction of the use of palliative care treatments, you might shift to a, as it were, more liberal policy over time as well.
Yes, and it's also based on the escalation from simpler painkillers to the opioids. And I think that is what happened in the US, is that the opioid painkillers started getting prescribed very freely, whereas you should always follow a cascade where you start with non-opioid painkillers, and then if it's really severe or persistent, you move on. But then you also have to monitor those people who are on those painkillers. You have to make sure that the dose they're taking hasn't been just creeping up and up. A number of things that you need to put in place when but it's really important it's available for palliative care. So you're exactly right that you will be achieving that balance, and for children especially, that you have a tiered approach. And obviously children who have cancer or other kinds of severe conditions causing pain, we need to be able to use the opioids, but it has to be done very cautiously and in a very thoughtful manner.
So we'll talk in a minute about perhaps strategy and thoughts ahead, but I think it might just be interesting for you to say a few words, a little bit about your background, kind of your research focus and expertise in India in particular, and maybe even how some of the issues that you encounter there, are useful in your reflections currently now on the global scale in terms of injecting more evidence-based policy and science.
Sure. So, I was interested in research from a very young age and was doing experiments and things in school. But then I went to medical school, and then I really wanted to stay in research. It's not easy in a country like India to really build a career based only on research. But I guess I was lucky I was able to pursue that. So I spent most of my life working on tuberculosis. And then HIV, as HIV became a big problem in India as well in the late 90s, early 2000s. And focused on a lot of my research was clinical research, clinical trials, epidemiology, but also I did a lot of lab work myself, hands-on work. But I learned a few lessons through my research career. The first is that you need a team. Research is a teamwork. It's never an individual. And none of what I achieved would have been possible if I hadn't had a fantastic institution and a team backing me up. The second thing was listen to patients, listen to communities. Very often doctors and scientists think we know what's good for people, and we often have a paternalistic attitude towards patients and communities. But I learned so much when communities actually turned around and questioned me about, why are you coming to us with this problem when our problems are completely different? Because in a village, in a tribal area of Tamil Nadu in South India, we were doing a project on TB. And when we spoke to the villagers, they said, yes, maybe one villager a year or once every 2 years gets TB. That's not something we worry about. But our children are getting diarrhea and infections, and there are no antibiotics in the primary health center. We have to walk for 15 miles, and then there's no doctor available there. Why are you not addressing those problems? You're talking to us about something that's not top of our minds. And I realized then that, sometimes we're focused on what we're doing and we don't see the bigger problem in the picture. So listen to the community. And the third thing I learned was that researchers, often we live in our own world. We like to publish papers, of course, in peer-reviewed journals. And you're driven by that, actually, if you're in an academic career. And ultimately, you may find that nothing is really being converted to policy or to practice. And what impact have you actually had? And so I realized the real impact on people is if your scientific findings are taken up by policymakers and used to make policy. And so when I moved to New Delhi as the head of the Indian Council of Medical Research, I really started working much more closely, both with politicians, with members of parliament, but also with the policymakers who sit in the Ministry of Health, in order for them to understand why evidence-based policies were a good idea. And I give you an example, I think, which stayed with me, is with the dengue vaccine. When it was to be introduced, there was a huge amount of pressure to introduce the new dengue vaccine, the only one at that time. We were not convinced about the safety evidence. We set up committees, and the experts said they were not convinced. Lots of pressure on me, but we said, no, we cannot recommend this. And I think it was vindicated, because what happened later in the Philippines was the children who got the dengue vaccine actually got more severe dengue when they had a natural infection. And so if something like that had happened in India, it would have affected millions of people. So you have a big responsibility when you sit in a position like that. When people, the media sometimes goes with a story about a particular outbreak or illness, which is not factually correct. And sometimes even politicians make statements which are not factually correct. And I think it's difficult, but you have to then stand up and defend and explain, I think, in an understandable way what the true facts are. And sometimes you don't know, and that makes it very difficult. There are outbreaks often which happen where you don't know what the etiology is, what the cause is. Is it viral? Is it a toxin? Is it bacterial? Everybody's giving their own theories. And in the middle of all that, you have to stay calm, and you have to you have to say sometimes that we don't know, we are investigating, and give us a little bit of time. But meanwhile, put in place some interventions which can save lives. But let's not rush to conclusions and start blaming people for what's happened. The HPV vaccine was another example in India where I was in the thick of things, because when I became the head of ICMR, I thought the human papillomavirus vaccine was a high priority for a country like India, which has the highest number of cervical cancer in women in the world. And I couldn't understand why we weren't going ahead with this policy. And then, of course, it was caught up with a lot of things which had happened in the past, including an HPV study where a few tribal girls had died of unrelated causes, but it had been conflated with the vaccine, and also some concerns that the HPV vaccine somehow would lead to more sexual promiscuity or all kinds of myths about the effects the vaccine might have. And so it was a long and hard battle for us, but we got the policy made, we started implementation in a few districts, in a few states, and now it's gradually picking up, though we're still behind some other countries which have implemented HPV. But the fact is, a lot of people told me, why are you taking this on? This is a difficult subject. You'll be attacked by all kinds of groups. It's better not to talk about this and just stay out of this controversy. And I said, no, this is what is right for the women and girls of our country, and somebody has to speak up. And if the Council of Medical Research doesn't speak up, then who else will? And so even though a lot of my senior colleagues advised against it, we went ahead. I got trolled on social media and things like that, but I think eventually we're beginning to change the practice.
I think, and hopefully, and I'll put it up in a second to discussions, and I think that intersection of engaging with the media and science journalists and the role of that in the influence on policy is a very interesting one. But before I open it up, just give us a little bit of a sense of the roadmap ahead of you now at WHO in your new role. What can we expect in the coming months? What will be the kind of the big, perhaps priority areas that you'll be focusing on in that intersection of science and practice ultimately?
So we have 3 areas that we will focus on. The first one I mentioned was, it's more methods and procedures. It's the quality assurance of all the work that we do. It's in ensuring that we're using the right methods, we're doing public consultations in the right way. It's really having standard methods to do all of that, but also very importantly to ensure that we're able to reach our audiences. We're still a bit outdated in the sense that we don't have all our materials available on apps, for example, that could be easily accessed. So we can, I think, improve how we disseminate our work and how we reach out to people. So that's one area. The second area is around research, and how do we promote research in areas that are of either neglected priorities or that are that need to fill unmet public health needs. So, for example, developing a research agenda around the triple billions. I don't know how many of you are familiar with the WHO's 5-year strategic plan, where we talk about the triple billions. So this is 1 billion more people achieving universal health coverage by 2023, which is in line with the SDG goals. 1 billion more people protected from health emergencies, and 1 billion more people living healthier lives, so which means well-being, the absence of disease. So it's really addressing prevention, promotion, care, surveillance, it's health in all policies, really, across all government ministries. So this is our 5-year strategic plan. So we would aim to come out with a research agenda in order to achieve the triple billion goals. So that could be one priority for us. The second is really to work with partners, public-private the product development partnerships, industry, the pharma industry to some extent, vaccine industry, to see what are the products that are coming up in the next 5 years or so that will need to be scaled up. What are the innovations out there which are very promising, but which all end up as small pilots in different countries and never get scaled up? So scaling up innovations which can have big impacts on, say, maternal mortality or tuberculosis would be also a big priority. Another area is global health, ethics, and governance. What are the big issues of the day that need to be debated, which have ethical implications? For example, gene editing in embryos. And many of you, of course, would be familiar with the case of the Chinese scientist who conducted these experiments on twin newborns, and he edited out a receptor gene because it would protect those babies from HIV, but you're tampering with the genetic code of an embryo, of an unborn child, and we do not know what implications that removal of that one gene is going to have on the rest of the body. Might have very negative consequences, and yet a Russian scientist has now announced saying that he's going to go ahead and do a similar experiment. And so the WHO set up a committee of top global experts, not just on gene editing, the technology, but also ethics, philosophy, science, law, etc., who will come out over the next 12 months or so with a framework and a consensus. But they've already put out a statement saying it would be irresponsible for any scientist in the world to actually undertake a clinical experiment with embryonic gene editing. So lab experiments are fine, they're allowed in many countries, but clinical experiments, there's a consensus across the world that this should not be done because we don't know yet enough about it. And again, I would like to make the distinction between somatic gene editing. That's to treat diseases like thalassemia and sickle cell. There's a huge potential now to actually be able to edit genes to treat those, and that should be pursued because that has huge public health benefits. But on the embryonic side, at the moment, no. So similarly, we're setting up a committee to look at artificial intelligence, big data, and ethics. What are the ethical issues we need to be aware of when we use artificial intelligence algorithms? And many of these are already being discussed. Biases that creep into the algorithm because you've trained the algorithm on a particular set of data. So if the data is all coming from Western Europe, for example, that application may not work as well in Africa. So currently we're engaged in developing a cervical cancer diagnostic tool which is based on artificial intelligence and based on mobile phone-based photographs, but we're making sure that this is developed in 5 regions of the world, a representative group of women, and done with the right ethical controls and approvals. And ultimately, if we have something like that, it would be fantastic because then you don't need pathologists to diagnose cervical cancer. You can do this. Any health worker can take a photograph and it would be automatically done. But there are lots of things we don't know, again, about how these algorithms work. And so a group would look at that. And then we'll have probably other areas like research in emergencies. When you have, in the middle of an Ebola outbreak, you want to do a clinical trial, how do you do that? Gene-drive mosquitoes. Do we want to eradicate all malaria-causing mosquitoes using gene-drive technology? What would be needed as an ethical framework to do something like that? So that would be big area of work. And then I would say that really empowering researchers in low and middle income countries to be able to work on the diseases which they think are important or on problems which are important for them. Currently, the global research funding, we have an observatory. It's called the WHO Research and Development Observatory. That gives you data on research funding, where it's going, who's funding what, which countries, what topics. If you analyze that, 99% of global research funding today goes to high-income countries, to researchers in high-income countries. And of course, the data is heavily skewed by the NIH, which has a huge, disproportionate amount of funding they provide compared to any other research funder. But even of the 1% that goes to low-income countries, most of the research money is going into communicable diseases, whereas we know that the burden has shifted to non-communicable diseases today. So researchers in developing countries say they don't have a voice yet in being able to drive the research agenda. So that, I think WHO has a responsibility to try and correct that. And then the third big area is digital health. I already spoke about artificial intelligence, but we have a department focused on digital health that would initially focus on the governance, on the regulations, on the guidelines, on interoperability and standard setting issues, because that's what I think WHO's core business should be. It would be impossible for us to regulate all apps, for example. There are already thousands of health apps out there. But what we can do is provide the standards which then countries can use to regulate which apps they allow and which they don't, or which digital technologies would actually have evidence behind them. One thing about digital technologies is that there's a very small evidence base of what works and what doesn't work. And very often we get driven because it's something new, it looks fantastic, but whether it actually makes a difference to somebody's health, or does it make the life of a healthcare worker easier? These are things which need to be questions which need to be answered in proper studies. And so, again, developing a research agenda around digital technologies would be useful. So maybe I'll just stop there. That's sort of framework of what we're looking to be working on over the next couple of years.
Well, thank you, sir. A pretty full agenda. Well, let's open it up, please, to who's got some questions. Yeah, I see one over there, please. Do introduce yourself as well, briefly, please. Yeah.
Hi. I'm Lydia Hales. I'm from Australian Doctor magazine. One of the top threats to global health by the WHO for 2019 was vaccine hesitancy. And sorry to ask a bit of a selfish question, particularly for my audience, being general practitioners. I was wondering if you could comment on some of the things that doctors can do, particularly in the context of, for example, recently in Australia we had a celebrity chef share an anti-vaxxer podcast to his 1.5 million Facebook followers. So what can doctors do about the anti-vax movement?
Thank you for that question. As you know, the anti-vax, there was a recent survey that was commissioned by the Wellcome Trust that looked at people living in about 80 or 100 odd countries. The striking finding there was that overall, I think over 80% or 85% of people believed that vaccines were safe and efficacious. But when you broke it down by region, it was actually the more educated countries where people had more doubts about vaccine safety. So 30% of people in France were not convinced that vaccines were safe, whereas 95% of people in Africa believe that vaccines are safe. I think it's partly to do with people not having seen these diseases. We don't see polio. Obviously, we don't see smallpox anymore. We don't even see measles till very recently. And so people do not know what serious diseases these are and how many lives they used to take before vaccines. And I like to quote Bill Gates, who says vaccines cause adults. None of us would be here if it weren't for vaccines. So I think general practitioners and doctors have a big responsibility in really talking to parents and prospective parents, and now even adults. There's a big immunization schedule in adults as well. So it's not only for children that vaccines are important. Adults need to take vaccines as well. And we've started seeing outbreaks of measles in countries which hadn't seen measles in many years. So I think really talking about the facts and the fact that the side effects and the safety of most, all the currently used vaccines is proven beyond doubt. And that if you decide not to participate in a vaccination, and if you decide that your child need not be vaccinated, it's not only your own child you're putting at risk, but the entire community. Because diseases like measles need a herd immunity. And for herd immunity, you have to have over 90-95% of the population vaccinated. And so you're doing yourself harm and your child, but also a public health disservice. And last year, measles caused over 120,000 deaths. So it's not a trivial amount. And I think people need to be reminded that these diseases kill and that they can result in permanent disability. You can be left mentally deranged or paralyzed after measles because you can get encephalitis. So it is not trivial. And perhaps even showing parents pictures of children who've had measles and complications. I mean, something to really convince parents that they're doing the right thing by vaccinating their children. And I don't know, I think there's something to do with the communication, obviously, that's gone wrong somewhere. And the anti-vaxxers seem to have reached more people than perhaps because we've been silent, because you just believe in something and you don't talk about it, the anti-vaxxers are more vocal, and rumors and myths get circulated very fast now on social media. And I think Facebook recently committed to trying to avoid or to deleting any anti-vaccine posts that may show up. So I hope that social media will also take some responsibility for this to avoid the spread of rumors.
Okay, thanks. Oh my goodness, lost. Should we go there?
Hello, I'm Ashima from thelifeofscience.com. Recently, you were talking with Sadhguru in Geneva, I believe. I'm curious how that conversation went. What's your reflection from this? And also explain a little bit about the context of this odd situation where the WHO chief scientist is talking about vaccines with a godman.
So she's referring to a conversation that I had with one of the Indian spiritual gurus who was visiting Geneva last week, Sadhguru Jaggi Vasudev. I think, spiritual gurus like him have a big following. Religious leaders have a following, and people listen to them and listen to their advice, and very often are influenced heavily by what they say. And I believe in, and I think Dr. Tedros, our DG, also believes in engagement with everyone, regardless of what your personal, except for the tobacco industry, where there's a red line, absolutely. But with pharma, with private sector, with food manufacturers, with the gaming industry, we've had conversations with everyone. So religious leaders play an important role and can do a lot of good if they send the right messages. So I think it's important. Our conversation was based on the health topics today which confront all of us, like non-communicable diseases, aging, artificial intelligence, how can humanity respond, what can individuals do, and what can communities do really to promote well-being. One of the questions there was on vaccines. He showed some hesitancy in the sense that he expressed a little bit of doubt about whether all these vaccines were really necessary. And so I came back after that response to say that there's strong evidence, the WHO has clear guidelines, there's absolutely no ambiguity about whether these vaccines are needed or not. The recommendations for children are based on sound evidence. And also mentioned the fact that people like him could really send the right message to the followers, which are in the millions. So I think overall the conversation went well. Of course, he talked about how spirituality could help well-being and how people need to take responsibility not only for their own health, but for the environment, water, earth, and so on. So I think all of those were positive messages.
Okay. Yes, please. Yeah.
Thank you very much. My name is Joost van Kasteren. I'm a science writer from the Netherlands, specializing in agriculture and food. I once interviewed your father. I hope he's well. I want to ask you something about the IARC, an organization under the umbrella of WHO. It issued a report in 2015 on glyphosate, Roundup Ready, saying that it's carcinogenic. But a year after, the Joint Committee of FAO and WHO issued a statement that it was not carcinogenic. So you're making life a bit difficult for science journalists on what to believe. Could you comment on the position of IARC under the umbrella of WHO, and will it be changing now WHO has a science division?
Thank you. It's a good question, and you're absolutely right. It's about communication. So the IARC, the International Agency for Research on Cancer, which is based in Lyon, in France, is a body which is governed by the WHO, but it has its own governance structure and it has its own governing body and so on. It's a scientific and a research body which focuses on cancer, and they do what's called the hazard identification. So they look at chemical compounds and see whether they have any carcinogenic potential. And they go by all the evidence, again, that's there in the world. And so what they came out with was a report which said that glyphosate was potentially carcinogenic, which meant that if you did experiments with glyphosate, in cells and tissue culture and so on, you could induce cancer. Now, what the WHO Joint Pesticide Management Review Committee does is really look at the risk of causing cancer to a human being based on the exposure. And that's how the acceptable limits are set for many pesticides and other chemicals that we consume in food and beverages, is based on the toxicity levels that you can be exposed to and the maximum level. So when we looked at exposure to pesticides like glyphosate, which would generally occur through food, the intake for anyone would be less than 1% of the maximum limit. So well under the limit that might cause a risk. And so the difference between the two was that the IARC looks purely at whether a substance, and this is similar for the red meat story, which was also quite controversial because they said red meat could cause cancer, yes, theoretically, but in the amounts that you eat, it's insignificant, the risk. So the same with glyphosate as well. But then glyphosate, again, has been looked at by other agencies as well, including the European Commission and so on. But that was the difference. And that, I agree with you, it created a lot of confusion. And so what we're trying to do in the science division is IARC is very much going to be part of the reforms that we're putting in place, so that before a report comes out, we evaluate all of these potential challenges with communication and risks and make sure that we have, that the message is clear, that we don't cause confusion by having two reports coming out saying two different things. So we learned from that experience.
So presumably you could have a much higher exposure for farmers and agricultural workers directly around glyphosate.
Yes, so people, yes, exactly. So for farmers and so on, you have to take the risk of exposure also through, because they're more closely involved, and also through inhalation route. So they would, but the report at that time looked at exposure through food alone.
Okay, all right. Please, yeah, there.
Good morning. I'm Disha Shetty from India Spend. My question is about the Zika outbreak in India a few years back. So when the first cases of Zika were reported, the information did not come to the Indian media or the general population. The government informed the WHO, and the Indian media found out through a WHO bulletin, and we don't know that was a few weeks later or a few months later. So my question is, in such a situation going forward in the future where WHO has certain information that the population of a country does not have, and I understand WHO has a stand of working with the government and not interfering with their, in their territory, what stand are you likely to take?
Yes, this is, I don't know if I can give a standard reply to that, because it, I think, varies from case to case. And I think what would be important would be to see whether there's a risk to the public by not informing and not having a public announcement. And if that risk were felt to be significant, then I think WHO would take a stand, would try and convince the government to make that public announcement or to take certain steps. In other cases, it may not be that case. You could find a disease, but it may not necessarily lead to immediate risk to others. As far as the international health regulations are concerned, I think the rules are clear about what governments should do when they find a particular pathogen which is on that list and what action they should take. And I think more and more countries are beginning to comply with that. Obviously, sometimes there are political considerations or other considerations. There are fears about trade being affected or the image of the country being affected, which could play a role. But what I observe is that more and more it's a realization by countries that it's actually beneficial to be transparent and open, to ask for help, to get technical support, to contain that outbreak or epidemic, and to take the right steps rather than to keep it hidden. So I think most countries who've signed up to the IHR now do follow those guidelines, and WHO would always encourage them to do that.
Okay, so yeah, maybe that. Thanks.
Thank you. My name is Ehsan Masood. I'm from Nature. Slightly different question. When we read the news, as we read the news, we get a sense that there's much less trust in multilateral institutions and in multilateralism. And I wonder whether, if you get that sense as well, being at the WHO, and what the implications of that might be in international public health.
Yes, it's true that there are some countries that are skeptical about the benefits of multilateralism. Overall, maybe there is a feeling, but what I've seen in the area of health anyway is that there's still a strong feeling of solidarity. And what I've experienced in the World Health Assembly, for example, is a very constructive debate. Of course, there are disagreements about things, but there's usually a very constructive debate, and it's very, very rare that the World Health Assembly ever has to vote finally on a resolution. So that shows that, consensus is usually achieved. Sometimes there's a bit of editing of language and things that needs to be done, but overall there's consensus that something that's of public health importance, that countries should come together to debate. One of these, I can give you an example, something that we're going to be involved in over the coming months and years is the public health implications of the Nagoya Protocol. As you know, the Convention on Biological Diversity, which was developed to protect biodiversity and to make sure that countries benefit from their own biodiversity and they're not exploited, unfortunately extended to pathogens as well. And so I think we've woken up a bit late now and realized that if a particular virus shows up in a particular country, it becomes their sovereign property, and then it's up to them whether they want to share it or not. And then there are all sorts of complications now with the Nagoya Protocol about sharing specimens. Now, this can be potentially very serious when we're talking about disease outbreaks, where you want data to be shared as quickly as possible, where you want specimens to be shared as quickly as possible. And of course, it's important that the benefits of that sharing be seen in the country. So whether it's benefit in terms of quick identification of the pathogen, or whether it's in terms of research collaborations and publications, or whether it's actually a product later that's developed, a diagnostic or a drug, you would want those benefits to flow back to the population for sure. But not sharing data in a timely manner can actually pose quite big problems for us in the future. So member states have asked WHO to do some work and talk to all the stakeholders possible, including the CBD Secretariat, and put forward to them a paper on the public health implications of the Nagoya Protocol, so that they can then debate and discuss this and see what's the best way forward to address the bottlenecks. First of all, they want us to just prepare a position paper to see what are the facts. So they said, we're going by anecdotes now, put forward the facts, tell us what's actually happened, whether there have been instances where lack of sharing has resulted in thing, and also tell us what the benefits of sharing could look like. So I think multilateralism in health continues to thrive. I hope it will continue to, because it's an area where you cannot afford to be isolated. In fact, we're talking more about sharing now, sharing of data, sharing of resources, doing more collaborative research. In the area of particle physics, we've seen the example of CERN. 95% of research in particle physics is open source and open access. But if you look at an area like health, it's a very small proportion. And I think it's to everybody's benefit to think more about sharing and collaboration in this space as well.
Okay, yeah, please, Andrew.
Good morning, I'm Moritz Borches from Springer Nature, Germany. And I was interested whether there are any specific upcoming programs with regard to tackling the global current cancer burden by WHO.
Yes, thank you for that question, because cancer is a growing problem. As you know, numbers are increasing every year. The capacity in most low-income countries and even middle-income countries to diagnose and treat cancer is very limited. And cancer is a big priority for us. As you know, one of our big flagship programs, the Director General issued a call last year for the elimination of cervical cancer. And we can eliminate cervical cancer, of course, in the long term, won't happen very fast if we scale up HPV vaccination throughout the world. And we also provide screening and treatment for women who already might have developed the early stages of cancer. So that's a very tangible call we have out, cervical cancer, and we've huge response to that. A lot of stakeholders working together to try to achieve that. So, but take childhood cancer. You can have, if you get childhood cancer in a developed world, you have an 85% chance of cure. If you're in a developing country, 15% chance of cure. So there's a huge mismatch, which means the drugs are available. You can treat childhood leukemias. It's just not happening. And so we have another program on childhood cancers to try to improve the cancer survival rates in low-income countries. We're talking with pharma about, with IFPMA on how we could make cancer treatments more affordable. But it's not only about treatment, it's also about the capacity for diagnosis. And that is where health systems really need to be strengthened. And I think in many, many countries, we've seen that you don't have the personnel, the resources in the primary healthcare centers, even in district hospitals, to be able to make a diagnosis of cancer. And as you know, with cancer, it all depends at what stage you're diagnosed. So we're not even talking now about the latest therapies like the CAR T cells. There are many cancers which can be cured now with existing drugs, which are now even off patent, and they're available as generic, affordable drugs. But we have to make them available, and we have to make diagnostics available. So we're starting with breast, cervical cancer, childhood cancers as 3 tangible ones that we want to make an impact on. And of course, tobacco and its link with many cancers. So if we can bring down tobacco use, you can bring down also cancer rates. Okay, but it is a priority, so thank you for mentioning that.
There was another question just behind, yep.
Thank you. I'm a freelance writer, Roland Fischer, from here in Switzerland. This is yet a bit of a different direction because I'm reporting a lot about AI, artificial intelligence. So I was kind of surprised and good to hear that you were mentioning artificial intelligence a lot. I guess when you were talking about possible regulations, setting standards, you were probably referring to AI in connection with health. But I don't know if you're aware that in more general terms, discussions about AI do refer to health policies a lot. So there's talk about maybe regulating algorithms and AI, just like drugs, and that we might need agencies like health agencies that could regulate algorithms. I just wanted to know how you feel about that, and if you feel like WHO could put out standards for a possible new agency about, I don't know, public digital health, or what, I don't know what that would be.
Thank you. Yeah, that's an interesting idea. No, exactly. I think how do you regulate AI as algorithms when it comes to health? Because we know one of the basic properties of algorithms is that they improve and they change over time as more data is fed into them. So the FDA has actually put out a white paper on how you may regulate artificial intelligence-based applications and how companies need to lock in something and then come back if they're revising the algorithm based on more data. So we're already talking to the FDA and the other regulatory agencies. In fact, we're planning a couple of meetings this year with regulatory agencies from around the world to think about how they might want to go about regulating these, especially diagnostics or treatments that are based on algorithms. And I think we don't have a clear answer of yet, but there's obviously a need, and there's been a demand that WHO really must take a leadership role in this. So we have, along with the ITU, a focus group on artificial intelligence for health, And that focus group over the last 1 year has been working in this area to try to document what's going on, what are the diseases which seem to be a high priority where AI is already coming into use. Obviously, in image analysis, it seems to have a big application, whether it's pathology images or it's X-ray and CT scan images. So that's one area, image analysis. But then there are other areas as well where applications are now even providing self-diagnosis to people. That could potentially be fine, but it could potentially be risky as well. And so there's still a lot of research and documentation that needs to get done for a particular application and how it might be used, when it's directly marketed to the public, for example, as opposed to something that's being used by a healthcare provider in a clinic. So more work and guidance needed. We're getting into this, and hopefully in a year or so we will be better informed.
And part of that will be your strategy for the World Health Assembly next May, right?
That's right. So we were asked by member states to develop a digital health strategy, so we're working on that. That will only provide a framework and an outline for what are the areas which are important, which need to be looked at. But one of them certainly is around the standards for artificial intelligence.
Okay, who else? One right at the front? Or two? You just come down.
Thank you. So there's more and more research showing how the first 1,000 days of life are, of course, very important. So I was wondering about new guidelines or new actions that you're planning when it comes to early childhood development. Thank you.
Yeah.
I'm a freelance journalist. Sorry, I'm a freelance journalist from Italy. Thank you.
Yes. Thank you. That's a very important area as well. And again, it's one of our platforms, our flagship programs, is on early childhood development, exactly because it's so important. We see that on the nutrition side, we still have a huge number of children who are stunted, 150 million children stunted, 50 million or so wasted. And on the other hand, we have almost 40 million children now globally who are overweight or obese. So I think having the right growth trajectory, especially in early life, is very important, because we know now that this has it makes epigenetic changes in the DNA of the child. That continues into adulthood and leads to diseases like diabetes and other metabolic syndromes. So what happens in the first 1,000 days, 2,000 days or so is really critical. But it's also the cognitive development and what kind of interventions are needed to ensure a child who's not only healthy in terms of physical anthropometry, but also cognitive, mentally is thriving and can then be potentially an adult who can maximize their full genetic potential. So we're coming up with a strategy on early childhood development, jointly with UNICEF, of course, because this is also one of their focus areas. And this is not that easy to implement, because, again, it needs a multi-sectoral approach at the country level. It's easy to develop a policy guideline, but to implement it, because I know from my own experience, it's not only the health ministry, but it's the ministries of women and child, it's the ministries of education, the ministry of culture very often, of sports, of many others that need to have policies which will allow this to happen or foster this. And so that this is an area where WHO thinks it's really important to work on. And it is one of our priorities.
Okay, one up there, please, behind you.
Good morning, I'm Michaela Lundell from the Swedish International Development Cooperation Agency. I wanted to ask you about communicable and non-communicable diseases and how to put priorities. As you said, there are very small, relatively very small streams going to research that is important for developing countries and to researchers working there. And then even if the burden of non-communicable diseases is increasing also in developing countries, don't we have to stick to prioritizing communicable diseases still, because by far those diseases, tropical infections, are taking much more lives still than the non-communicable diseases? Or what's your view?
Thank you. Yes, it's not a question of choosing one or the other, but being able to respond to the changing disease burden and changing epidemiology. So while, 20, 25 years ago, it is true that most of the deaths in low middle-income countries occurred because of communicable diseases. Today, the situation has been reversed. And even in low-income countries, it's now more than 50% of the disease burden and the mortality is because of non-communicable diseases. And it's happening silently, but very quickly. Now, there have been focus programs for AIDS, TB, and malaria, the Global Fund, Gavi for immunizations and so on, and also special programs for neglected tropical diseases. And while there's no doubt that these continue to be huge and important, I'm a TB researcher myself, and I think in this day and age, if 1.5 million people are still dying of tuberculosis every year, we still have 10 million new cases of TB every year. That's not acceptable. We have 1 million deaths due to HIV and still over 2 million new cases of HIV a year. So certainly there's work to be done. Malaria, we've seen, in fact, a plateauing and a slight increase. We had 230-odd million malaria cases and 500,000 deaths, mostly in children. So certainly the importance of these, we cannot say we've solved the problems and let's move on. Absolutely not. But what we're trying to say is that countries need to be aware of the creeping and increasing burden of NCDs, of cardiovascular events, heart attacks, of strokes. And these diseases are chronic and they cause a huge burden on the individual, the community, but also on the health system. And so if you have someone who's had a stroke, that person can't work anymore. If a stroke at a young age, like we are seeing in India now, the median age of stroke is in the 40s, and heart attacks as well. That person then becomes invalid, his family suffers, the health system costs increase, and so on. So on the one hand, so the health systems have to change from being oriented to dealing only with acute infectious diseases and acute maternal and child illnesses, which is what was there in the MDG era. That's what we were faced with, to the era today where we're talking about having an integrated approach and a more holistic approach to health, where you don't just say, now I've cured you of TB, but that person actually was diabetic as well, but we didn't do anything to address his diabetes or his hypertension when we could have and put that person on treatment. So the issue is really, let's think about non-communicable diseases and how do we manage. And I can tell you that in most health systems, the strategies and the policies are not in place. Health workers are not trained to handle chronic disease. They're trained to take care of people, and then they get well, and then they go home. So it's a whole shift, and that's why we talk now about universal health coverage, because UHC really, and primary health care really should encompass all of this. It should encompass not only disease detection and treatment, but also prevention and health promotion, and also rehabilitation and palliation, which again is lacking in we have data now on the lack of assistive devices, and the lack of basic things like hearing aids and spectacles that can make quality of life much better for people who are aging. And so considering the fact that we are all living in a world where we're going to have more people above 60 than under 15 by 2030, we really need to equip ourselves for a world that will have diseases associated with aging, and keep people healthy, actually, as they get older, not just look after diseases, but try and keep them healthy and have a good quality of life. So that's the balance. It is difficult when countries need to prioritize limited resources and they say, shall I put it into malaria or shall I put it into hypertension? But that's where data and a good analysis matters. So if you're sitting in Central African Republic, you have X number of dollars, what should you prioritize? Maybe different from if you're sitting in Brazil or China or India and you're trying to prioritize. So I think local data, being able to analyze and use that to make your health policies is important. And that's why we're also putting a lot of importance on strengthening country health information systems and data analytic capacities.
My name is Ochieng. I'm a journalist from Nairobi, and I work with a media house called SciDev. My question to you is on the Ebola in the DRC. I think for about 10 months now, Ebola has been ravaging DRC, and recently it spread to Uganda, where there were 2 deaths. Between 2013 and 2016, the same case happened in West Africa, and the response was so slow, as it is slow in DRC, despite the fact that that is happening. And I think WHO has been accused of being very reluctant in making appropriate interventions when it comes to the DRC case, as was the case in West Africa. Yet, when there was a single case in the US, WHO moved in very fast. As the chief scientist of WHO, do you think the way you are handling the DRC case is the right way it needs to be handled? And going forward, do you think you will do things differently in handling situations like that one, especially in the developing world?
Thank you very much. I'll address your question, but I just want to say also there's going to be a special session on Ebola this afternoon, and Dr. Mike Ryan from the WHO, he's the head of the emergency program, is going to be here. The session, I believe, is between 2 and 3, and he'll be interviewed by Helen Bronswell, and he will have the latest. So anybody interested in Ebola and DRC, please to come to that session. And also tomorrow, I think there's a field visit planned to WHO. You can meet with the Director General, go to our shock room, the Strategic Health Operations Center in WHO, where there's live connection with all areas where there are outbreaks. And so we still have few slots for anyone who might want to register for that field trip to the WHO. But coming back to your question, the first Ebola outbreak in West Africa, the international response was slow. It took some time to realize and then get our act together, I think. Ultimately, the world did come together, and WHO played an important role in the control response, but also in testing the Merck vaccine. In the midst of that crisis, in the midst of the outbreak, WHO was able to pull together a protocol and conduct a vaccine trial that actually showed that the Merck vaccine was highly effective. As you know, in the DRC outbreak, more than 140,000 doses of that vaccine have been given to contacts of cases, and that's probably is the factor responsible for this outbreak not being bigger than it is. The outbreak in eastern DRC is very different from the one that happened in Equator province, which was controlled, by the way, within 2 months. There were about 75 odd cases. I also went there with the Director General last year. Vaccine was used, it was controlled. Eastern DRC is, you know better than me, probably the area of conflict, violence, displacement, political unrest, and a whole lot of security issues. As you know, we've lost 5 of our staff members there, including a doctor from Cameroon who was shot by rebels who came into the treatment center. They've burnt down treatment centers. It's not an easy environment to operate, and I think that's the issue we're facing today. It's not just a simple case of controlling Ebola, but it's operating in that environment where the health teams are regularly attacked and cannot go into villages to vaccinate people. So I think given the circumstances, in fact, it could be much worse. And being able to vaccinate 150,000 people in that kind of situation where people get attacked when you go into villages is, I feel, that people there have suffered a lot, and now they're suffering from this. The other thing I'm sure Mike will talk about is a basic lack of health care facilities, primary health care facilities. And if you don't have that, then outbreaks like this, can flare up. Infection prevention and control is so important. Healthcare workers, they need to be protected. They need to be aware as well. So a lot of things which need to be built and strengthened for the future. But Mike will have many more details this afternoon.
Okay, I'm afraid we've really, we're sort of right up against the end of time. I don't know if you just had a final provocative reflection to a group of scientific journalists about the importance of engaging around scientific and particular health issues. Is there a message, a request to them, or an offer from you that might be a parting word?
Thank you. I was saying before we started this session that, in fact, it would be wonderful to have feedback from journalists to the science division on what kind of communication from WHO is effective, what's not so effective, what works, how can we make journalists all over the world pay more attention to health issues. Somehow health issues tend to get into newspapers and media only when there's a sort of a disaster happening, so there's an outbreak and, there are lots of people dying, then it, and I used to say in India, 1,000 people die of tuberculosis every day. I've never seen it on the front pages of the newspaper. But one person dies of dengue in the capital city. It's on the front page. It's a big headline. Because the person died in Delhi, the person died in a private hospital, and the person was from a higher socioeconomic group. I mean, that's the only thing I could think of. And all these people with TB dying in remote areas or dying in urban slums or wherever, invisible. And so we really need the media to bring stories out which affect the common people, and especially things which are not talked about very often. And sometimes maybe they're very dull and boring, and that's why it's difficult to make a story out of it. But it's still important to get people engaged, and I really would like feedback to learn more about how we can help you, journalists, to really bring, as I mentioned a few topics earlier, to get public debate going on issues where public needs to have a voice. And they need to express themselves as well, because that's often something that drives governments and drives policymakers to have change. We saw in HIV, what made the difference was the activist community. If it hadn't been for the gay community in the United States, we probably wouldn't have had all these HIV drugs that we have today. So they drove a lot of the research. And finally, I just want to say we have a small flyer on the new WHO Science Division that's available up here for those who want to take a copy. Just describes what we've been talking about. It's very short, but it gives you an overview and also has our contact email and so on. I'm available on email, on Twitter, and happy to engage in the future. And thank you all so much. This has been a wonderful interaction, Andrew. Thank you very much.
Thank you.